immobility may not always be negative. What do we think maybe it wouldn't be negative?
Have an injury that requires not.
Right. Or surgery, if somebody gets a rotator cuff, they're not going to just start moving their arm. They have to keep it immobile for a while. So categories, we have neurologic and musculoskeletal. I know that you guys went over some joint and muscles and all of that stuff and bones last year in second semester. This semester, we're talking about things that impact mobility due to neurologic disorders. Since all movement is coordinated through the brain, we have that neuron-to-neuron transmission, and all these signals have to go through. We're going to learn about some things today that can alter that. Again, this is your physiological review, so it's not necessarily something you need to study for the test when you get to Parkinson's. That's when you really start having one studying. So you get to infancy, childhood, adolescence. So what things, why is this important? Why do we need to monitor this for children? Yeah, how their growth is. Last Wednesday, I took both of my kids, and my daughter's almost 8, and she's 45 and a quarter inches tall. My son is 40 inches tall, and he's 3. So she is in the 3rd percentile. He is in the 90th percentile. So we can see why it's important. We got to see why, if they're gaining weight normal, but especially if they're growing like they should. Adult and aging adult. So some common things that we see in normal aspects of, getting older in that older process is some thinning going on. The ones that have kyphosis. I don't know. Do you guys have Facebook? Because they have this new. I don't know if you guys seen this or not. But there's an exercise for kyphosis. And so what you tell patients to do is put your arms like this, and they stand against the wall, and they move their arms up. And it's supposed to help that spinal column, which I think is awesome. So that's something that you can help with your patients and educate on as long as the doctor's okay with that. Bone density reduction, why does this happen? It's very common among women.
Because of hormones.
The estrogen. Yes, when we have that loss of estrogen during menopause. So a lot of times with women, if they've had fractures, like if they were younger and had fractures, as they start getting older, then we start doing, even if they haven't hit menopause yet, we can start doing bone density scanning and testing because we want to make sure they're not even more at risk, and we want to give them medications to help them to reduce risk for fractures. And then they have muscle mass and tone decreases as well with age. Consequences of immobility. These things you may probably just know that is common and it happens among patients when they're immobile, but then these are things that you need to remember because as we talk about mobility, then this stuff all makes sense. So obviously physiologic, psychologic, people may get bored, they may be depressed because why? They can't move like they used to. In the urinary tract, they may have urinary stasis. They may have leakage in their bladder. Why?
Losing the muscle tone.
You're losing the tone. It's just like any other part of our body. It loses tone. We also see leakage of the bladder after babies because of trauma, things like that. GI, everybody complains of constipation. Because the more we move and the more we're physically active, our motility in our gut moves. If we stop moving, then that slows down. And that's why people have constipation. So patients that say, well, I have constipation, and maybe they just had surgery, so of course they don't want to get up and move, right? And if they're sore, they don't really want to get up and move. And maybe the opioids, that can also go hand in hand. But we can educate on the importance of getting up, moving around, the importance of drinking a lot of water and fluids to help with that. Skin breakdown. And this happens very quick. Katie had a patient a week or 2 ago, not last week, I guess the week before last. And he had only been in there, 2 days? And when we bathed him, he was already had a stage 1 on his bottom. So that is why I'm an advocate for checking their skin, turning them, because, they said he was mobile, he was able to turn, but he already had a stage 1 on his bottom. So that is why we need to be better at checking these things, because if you've ever sat in a class for 6 hours, 7 hours, I don't even know if you've ever been in a class that long, but if you ever have been, if you get up and you go to walk out, have you ever felt your bottom and it feels numb? Why?
Lack of circulation.
Yeah. So that's what happened to them. And you think about 2 days straight without a person, and I know he wasn't moved because he was not bathed. And so that's something to just kind of keep in the back of your mind why it's so important and why we need to monitor patients. As far as muscle mass goes, when they're in a bed for 2-3 days, maybe they are elderly or young children or something. So when they get up for the first time, they may be very weak, right? I mean, their massive, oh my gosh, muscle mass decreases, so that's what makes them so weak. And then their respiratory. So when they are sitting there, they are, laid up in a bed. They're not really doing their turn, cough, deep breathe exercises. So we have a reduction in lung expansion. And then we have pooling of secretions, which increases the risk for what? Pneumonia. And then our cardiovascular system, we would see maybe possibly a reduction in cardiac output. The vasculature changes. We have maybe vasodilation occurring. So then the blood just kind of sits there, and then what are we at risk for? Clotting. So that's what we see with immobility. I will get into more detail when we go into Parkinson's and things like that, but these are some assessments that we can utilize when kind of trying to determine what is going on with our patients, and maybe ask them questions, past medical history, exposures, because that is important. Current medications, we think of cancer treatments, we think of steroids, things like that that can affect the bones. But again, those are things that we can just incorporate, whenever we're talking to patients and trying to figure out why they're immobile. Diagnostic testing. So we do have a lot of tests, and you'll see today when we're going over some of the testing, you may see MRI, which can be diagnostic for some of these, but CT, X-ray, sometimes we're just trying to eliminate other things before we kind of go to like neurologic disorders as to why somebody is immobile. We do see the electromyography with some of these when they're testing the muscles. And now we get into Parkinson's disease. It's one of the most common neurologic disorders. Most commonly happens in men. In my family, it's in women. So, but they say it's more common in men. So take that and leave it. Primarily idiopathic disease. However, it can occur due to antipsychotic drugs, which we will hit later on in the semester when we talk about schizophrenia and those medication treatments. Brain tumors may also, you may see patients with Parkinson-like disorders. So the 4 cardinal symptoms that you need to be mindful of are these 4 right here. Because there's things that you see as far as interventions and why we need to intervene due to these symptoms up here. The first thing that we notice with Parkinson's disease is what's called pill rolling. So these patients will sit and they'll do this. So that's why you have to be very analytical. I'm very analytical. So when I sat and watched people, one thing I noticed, my great-grandmother had this, but I mean, at the time I remember her, she was already tremoring. But my grandmother, a few years ago, she'd sat in her chair, and in her little lazy boy, she'd always have so her hand on her armrest, and she'd do this. So what is that? The same thing. Is that not like pill rolling? Instead of just doing this, she's doing this. So I'd say, hey, Mom, you probably need to get grandma checked because, that's kind of one of the first symptoms. Do they ever listen to me? No. So now she's to the point she does tremor. So you have to think outside the box. If you think pill rolling and you just think this, then you're going to miss other symptoms because not everybody's individualized. So you can't just think this. you have to think of something similar. So even if it is on a chair that they're doing this, or maybe it's their leg, but you just have to watch for those things. Tremors is one of the first symptoms after the pill rolling, and it's in one, like usually unilateral situation. So whenever we notice tremors, one thing we can ask patients to do, because this is going to be opposite than MS, okay? So with these tremors, they actually get better with doing something. So if I say, Mindy, button your shirt for me, and you're fine, and then all of a sudden you go to button your shirt, and then you start tremoring, that is something that we actually know. Opposite than that, when she goes to button her shirt, she does not tremor in Parkinson's. Okay, so it's opposite of MS, and we'll talk about MS with the intention tremor. So it gets better for those with Parkinson's disease. The pathophysiology part of this, it's not really, you do not need to memorize this whole thing. You've already had patho. What you need to know is what we're dealing with is dopamine and acetylcholine. Acetylcholine is our neurotransmitter that does what for our body? It's what allows us to move in the first place. The reason why we don't all tremor is because we have dopamine that refines that movement. So it's like checks and balances. We have to have one, we have to have the other for our body to be happy. If there's issues in the production of dopamine, then we have what type of movement?
Erratic.
Yeah, involuntary, erratic. So that's what happens with the dopamine. Things that we also may see with a low dopamine level is autonomic nervous system issues. So there can be issues with our heart rate, sleep, attention, mood. Patients can have low sex drive. And it may seem silly to question that, but that's an important part of people's living. Stages, we have stages 1 through 5. Again, you do not need to memorize this. The biggest thing is understanding how it starts, how it begins, and where do they end up on stage 5. They're completely dependent on something. So again, tremors, things that we may see if it does increase with stress. So what do we need to do with these patients? We need to educate family members to reduce stress on their family. Rigidity occurs with the muscle groups, and this is just not in the extremities, okay? You have to also understand there's muscles in our faces. So we also have facial issues. So when they're chewing, when they're swallowing, their ability to do those things can be impacted. Emotional, so they may become more moody. So if the patient is beginning to be moody, and the family is really complaining about this, how do you explain this?
It's a disease pattern.
It's the disease process, the dopamine level. So we can't just say, well, you got to understand they're not moving like they used to. That has nothing to do with it. It could, maybe. Maybe they are upset they can't do the things they used to. But more than anything, what it is related to is the fact that the patient, the physical Okay, so then we have speech patterns. So again, if they have rigidity in their facial muscles, we may notice slurred speech. Doesn't mean we need to tell the family, hey, I wouldn't take them out in social, public areas just because they do have some slurred speech and you wouldn't want to know. You keep them socially active, things like that. But you just educate that those are things that it is common due to the rigidity of the muscles. And then they do have bowel and bladder issues. So things that we do see, we see the stoop posture. So if we are supposed to, when we're walking, I know some people slump, slouch or whatever. But one thing that we see with these patients is when we're walking, we're upright, right? We're standing up. What happens if somebody's kind of tilted down? I mean, I'm already kind of falling over on my tippy toes. So it kind of throws their weight off. So now we see why they are falls risk. They do shake. They have that forward tilt. They have the flexed arms. They do not really swing their arms. So when you go to the bathroom today, try really hard not to swing your arms as you're walking. Just try to hold them down. It isn't that bad, but for a patient that's already slumped over, it can really throw them off as far as when they're walking around. They have shuffling short step gaits, and I'll show you guys a video in a little bit of a patient, not a patient, but he's just showing you what they do. So they shuffle their feet. So what are they at risk for when they're home? What do we need to make sure of? No ruts. In the hospitals, I know the mats are good as far as, fall risk, things like that, but we also have to be very mindful of a person maybe getting up out of bed and going to the bathroom that has Parkinson's, because if they have those mats around their bed, we want to be there. Because if they get up out of bed and then they come back, they can hit those and then they can fall. So it's really hard for them to take those big steps. They do shuffle. When you think of the mask-like facial expression, the rigidity in the face, these patients also have a lot of drooling that happens. So if you have an issue with the ability to swallow, what happens with all those secretions? Try to not swallow for an hour and see what happens. You get choked up. I mean, it can cause aspiration issues with these patients. So we want to be mindful of keeping their head of the bed elevated, because they're not going to be swallowing like we would. As far as chewing, the ability to chew, we're not going to give this patient a hefty steak and say, eat it, right? I mean maybe if it's a real soft piece, water, I don't know. But you got to think of foods that are easier to chew for these patients. Good protein, but they're able to chew. Yes, very small bites for these patients. Again, with the autonomic nervous system, we kind of went over, and I think there was a list, the next slide, of things that we do see with these patients. So again, when patients begin, or family members begin to say, oh, all these other things are happening with our patients, we have to say, well, that's common because due to the low dopamine. They may have no clue what you're talking about as far as dopamine. But you just say it just goes with the disease process. It happens due to the same reasons as causing the tremors and things like that in the patient. Again, swallowing issues with these patients, falls, injuries, so a lot of safety around these patients. Diagnostic tests, there's really no specific test. If they think it could be Parkinson's, they give a medication, prescription medication, and if they see that it gets better, then they're like, okay, well, we can pinpoint this as Parkinson's disease. There's also something that occurs due to the low dopamine level, and when patients start getting confused, they may lose their short-term memory. This dementia is called Parkinson's dementia, or when the patient has passed away, they can do an autopsy, and they sometimes will see these things in the brain called Lewy bodies, and that is clinical. It goes right with Parkinson's disease. So once they start getting confused, we treat it we may give them medication just like we would if they had like Alzheimer's disease. But it is confirmed. That is confirmed on autopsy. That's like the only thing they'll do is they'll say, okay, did all of these mobility issues begin before the short-term memory loss and all of that? And if it did, then they say it's Parkinson's, a dementia. But if the dementia happened first and then all these things, then they wouldn't even relate it to that. Okay, what do we have here? A ton of medications. What I want to do is start down here on these medications. So Effexor. You know what Effexor is? It's an SNRI. It's for depressed patients. When we talk about one of the treatments up here, we have an add-on MAOIB inhibitor. If you do not remember these medications, you remember what about MAOIB inhibitors? What are some things that you cannot do with these medications? What about diet?
Fermented foods, right?
Yeah, the tyramine, anything with tyramine, you have to avoid. Another thing to understand is medications we commonly use to treat depression and things like that are contraindicated with these medications. So we could not take this and this together. So if you see that, you would definitely tell your physician, hey, we can't do that. Because SSRIs, SNRIs, TCAs, all of those we cannot do with MAOIB inhibitors. What can it cause if we eat tyramine and we do these things? What does it cause?
Cardiac problems.
It basically causes a hypertensive crisis. Ambien. Why do we see Ambien on their list? Yeah. Due to that low dopamine that affects the sleep. And then we have Cogentin, Artan. These are for severe motor symptoms. So again, we're treating symptoms. These are often avoided in older adults, and there's a reason why: anticholinergic effects. So what are anticholinergic effects? Yes, and you should always remember anticholinergic, because if you ever see what are anticholinergic effects, you should automatically already know what those effects are. Exelon. You have add-on medication for that dementia. So again, if they start having dementia, we'll often see that medication prescribed for it. Simitrel is a medication they often give with Parkinson's, and the reason why is it reduces the dyskinesia that occurs with a lot of the medications we give for Parkinson's. So it's just, again, an add-on medication. The Parlodel promotes the release of dopamine. We've already went over the MAOIB. Compton, this medication is given again as an add-on because what it blocks is the enzyme that breaks down dopamine. Why do we want to block the enzyme that breaks down dopamine?
Part of the lower amount of dopamine.
Yes.
You're trying to bring it up.
Yes. So that is why we give Compton. Now I'm going to go to the top. Mirapex, Requit, Nupro. These are given as dopamine agonists, meaning they mimic dopamine. They are not dopamine. They just mimic it. The only good thing about this medication is it's not as effective as levodopa. However, the reason why they give this medication is because it does not cause the dyskinesia like the Sinemet and the plain old levodopa does. So that is it's maybe better tolerated, but with patients that have Parkinson's, then you often see them go to Sinemet. Levodopa is just straight dopamine. It actually turns to dopamine. Let me say that. It converts to dopamine within the body. Levodopa is okay, all right? Let me just say that. However, what happens, there's a difference between the Sinemet with levodopa and carbidopa and just levodopa. Do you know the difference? I know one. I mean, there's one with two medications, but what's the difference?
Doesn't carbidopa help more levodopa go over?
Yes. So what it does is levodopa will break down in our body. It'll change to dopamine within our systemic, right? All of that. So before it even crosses the blood-brain barrier, it converts to dopamine. So when it gets to our blood-brain barrier, we probably don't have a lot, and that's where we need it. We need it in our brain. So with the carbidopa, like you said, Bree, right? Like Bree said, carbidopa kind of holds it together. It says nobody's touching this medication until it gets to the brain. It holds on to it all the way to the blood-brain barrier. So once it gets to the blood-brain barrier, carbidopa has to let go because it cannot cross. So then levodopa goes into the brain. It converts there to the dopamine. And that's actually why it's a very good drug. because the carbidopa allows it to stay intact till it crosses the blood-brain barrier. The risk for these medications, again, it can lead to dyskinesia. We also have to educate patients with these medications, the levodopa, the Sinemet, even the Nupro. There are risks of hallucinations, suicidal thoughts. So if a patient is on it for long term and we start seeing, like maybe they're seeing spotters, should we let the physician know? Yeah, I mean, we definitely need to let them know that. Even if they say, well, this can happen, that you still need to let them know, because we really don't want patients going through that. So yes, this seems like a lot of medications, but when you see that the gold standard treatment is this, and then this is an add-on, so I mean, obviously we have, more dopamine because of Compton, because it eliminates that enzyme or blocks the enzyme so that it doesn't break down that dopamine, so that it allows our body to have that. So a lot of add-on medications, but then we're seeing things that treatments for the symptoms that go along with Parkinson's. Additional interventions. So PT, OT, do you think we should do speech therapy maybe? Yes. Yoga, dietary support. And I will say with speech therapy, can nursing assistants feed a patient? Yeah, they can, right? I mean, that's common. They can do that. With a patient that maybe they're having swallowing difficulties, should we allow them to feed them? No. So here is your clinical judgment. Here's when you would see as a nurse the things that maybe you should not delegate. Not that I haven't seen it delegated before, but things that you need to be mindful of. Psychological support, again, patients can be very depressed with this, and their mood can change, so again, we may have to medicate that. And then we may have some surgical procedures. One of my husband's, actually, a family member of his, had to have, I don't know what he had. I think he had the deep brain stimulation, but whatever he had, it's supposed to help with reducing the tremors. Really, this is individualized based. Some people it helps a lot, and some people it's not as effective. They do tell these patients to exercise to keep their muscles obviously strong. They can have those involuntary muscle movement. Some patients, you may see them just take off running. Some people, they may get stuck. So if they stand up and they go to walk, and they'll have these episodes where they just get stuck. They cannot move. Things that you can help them with initiation is tell them to march in place, and that gets their legs going, or pretend they're stepping over a line, because that is the act of marching, right? You're stepping over a line, you're pulling your leg up, and that initiates movement. They have said to take 2 steps back, 1 step forward. I don't advise that. I think that's more of a safety concern. Maybe you could do it if you're there with them, but I would be very cautious of that, because going backwards, I can't even hardly walk backwards, and so you just have to be careful with telling the patient to do that. So if you ever see it, it is common, but I would just be cautious of doing that. They even say to rock back and forth. Again, be careful with that, because of if they're already, kind of thrown over and you're telling them to rock, that may throw them off as well. Fall precautions, so in-home things that we would educate on, especially small pets. I love animals, but a lot of times little small dogs like to get around their feet. So we want to educate them with just, probably keeping the dog away when they're up moving around. Monitoring their food intake. So we already know they may have swallowing difficulties, so we need to monitor their weight. And why do we need to monitor their weight? Right. Because some families may be nervous. Well, we'll just feed them once a day, and, but we really need to be very cautious of that. Fava beans, things like that, to help with constipation, because they may not be up moving as much as they used to. Fiber, that can help. I've heard families before say, I don't give them a lot of water because all they do is want to pee. Yes. So what you can educate on is giving them something to urinate in, getting them a urinal, because that, I'm going to tell you, that happens a lot. Or they don't want to pee in all over. Elevating their head of the bed to maybe 45 degrees. You got to remember their risk of aspiration. They may eventually be put on a mechanical soft diet. Massage, things like that can help with that rigidity. Huntington's disease. This space is hereditary trait. So these patients that are diagnosed with Huntington's disease have a 50% chance of passing it on to their offspring. Usually when the symptoms begin to occur, they say 10 to 30 years is what maybe their lifespan, how much more time that they have. Average is 15 years. They're usually pretty young when they're diagnosed with this. So we see Parkinson's kind of in the elderly population, and the signs and symptoms that we see with Huntington's disease kind of mimics Parkinson's. So they may have involuntary jerking, tremoring, impaired gait, difficulty swallowing, speaking. They may have a lack of awareness. Maybe their mood changes. Withdrawn from patients, fatigue. So that's similar to Parkinson's. A lot of similarities. So what sometimes happens is if they're younger, we begin to think Huntington's disease. And and this happens a lot, but if they are younger than 20, it's called juvenile Huntington's disease.
They say that's rare. I don't know how rare. I do know that, I don't know, probably about 15 years ago, I worked in a nursing home down south, and in this one nursing home, we had 4 patients with Huntington. And they said that was rare.
Where was that at?
It was a small town called Elizabethtown,
Where'd you say what state?
North Carolina.
Carolina. See, I often wonder because they say it's genetic, but then also they say maybe, could it have been environmental things that, have to, I know they're still doing research on it, but you gotta wonder, like, maybe areas.
Well, 2 of our patients were mother and son.
Mother and son.
Different age groups. I mean,
So a lot of times what, one thing, because it is hereditary, and you have a 50% chance of, it is kind of a hard, maybe, probably a hard pill to swallow. Because sometimes if they already know they have Huntington's, a lot of patients, what do they say? Like, I really want kids, but I don't want to risk that chance.
Right.
Is it the last thing they can do? I mean, obviously, if there's IVF, which is very expensive, but there are things that they can't do. Adoption, right, yeah. But with IVF, they want their own kid, because that's a lot of people's desires is to want that. So sometimes they can do IVF, and they can look at, once they put the egg and the sperm together, they can test the DNA, and they can see if that gene is in there, and if it is, then they just do not insert that one or implant it, but they can do the other one. So that's a way to do it. However, it's very pricey, but there are things that you can educate these patients on. The family planning is usually one of the biggest. When they go to genetic counselors, they discuss that with these patients.
The youngest, a friend of mine, the youngest patient I knew down there she was a teacher, and she was mid-20s, and her father had it. And this friend of mine fell in love with her. I mean, they were dating and everything. I mean, it was a beautiful relationship. And then she was diagnosed, and she started going downhill real fast. And he still married her, and he's still caring for her to this day. So he could probably, I guess, maybe 10 years ago,
young people, if they are diagnosed before the age of 20, so what they really see is a loss of those learned skills. So maybe things in school that they've learned, they start doing. Maybe they did really good, they were outstanding students, and then they start doing worse, and that's what they kind of notice with these patients when they're young.
What was the blank up there?
Hereditary trait. So safety measures, again, similar to what we talked about, falls, speaking, swallowing, all those things. Supportive care, treatment is going to be based on your symptoms. There's really nothing, I mean, we cannot cure this. Speech therapy, PT, OT for these patients. We may assess their reflexes. Again, really, the biggest thing to just understand of this is like your supportive care, your interventions as far as that kind of go hand in hand with what we talked about with Parkinson's. But then just understanding that it can be passed to the children because family planning, really what we would do if you were in, like, as a nurse practitioner or a nurse and you see, like, the physician will already talk to them, but you can kind of be that advocate and talk to them about, you know, if they want to see a genetic counselor, things like that, because that is good for them to follow up with someone about this. MS. MS is a chronic disease. I'm going to tell you guys, they are still studying this because they are still unsure what really, they do know it's to be the immune system, genetics, infections that have happened for the patient. But what happens is it attacks the myelin within the nerve fibers, which can cause permanent damage. So we have periods of remission and exacerbation. So they may become weak, and over time they may think it's nothing, but then they get better, so they kind of blow it off, like most patients do. I'm fine, but then it happens again and again and again. Okay, those are called exacerbations. Exacerbations is what causes the breakdown and permanent damage to the CNS.
You said that it attacks the myelin and the nerve fibers to destroy what?
What do you mean? Oh, destroy the CNS. I'm sorry. So with the exacerbations and with the damaging of the nerve fibers and all that, what they can see on MRI are things called MS lesions. And it's just white, it kind of just comes up as little white spots in the CNS and like the spinal cord, things like that. And so that's when they can definitively diagnose a patient with MS. Early on when this happens, it's kind of like a process of elimination because maybe they may not see those MS lesions if it hasn't been too long that this has been going on. So it's very hard to diagnose at first. My nephew is 7 and they haven't done an MRI on him yet, and I figure they will in the future, but they were just trying to see maybe if he possibly had this because he has what's called intention tremors. I mean, since a young age, I could almost tell this was kind of going on because an intention tremor is when they go to do something, the act of doing something, they begin to tremor really bad. They'll be fine, especially him, he'll play, he's fine, but if he goes to eat, he goes to take a bite of food, and it just goes off his fork. If he goes to drink, we have to make sure there's something on his lid because it'll go all over the place. My husband took him to the bathroom at a Mountaineer game, and he came back and he just sat down. He was just looking straight ahead. I'm like, what's wrong? He's like, I said, what happened? He said, Kathy, he peed all over. He peed all over the wall. He peed all over everything. And it's because when he went to hold himself to go, he couldn't. He shook so bad that it went all over. So those are things called intention tremors. So the act of doing something, and that's what makes them tremor. There are 4 major types. do not even go over this because they're changing these. Last time I looked, they were talking about 3 types. Don't even, this was back whenever, I mean, they really thought there were 4, but now they go to 3, then they go back to 4. What it is it just says, so their remission and their exacerbations. Maybe they never go back to, their normal life and they pretty much go with just small exacerbations. That's a stage. The ones that keep going back to remission, that's a stage. So again, the more they exacerbate their symptoms, the more damage it's doing to their body. Key features. There's a lot of key features up here. What they've seen with these patients is it can start in their eyes. They may have optic neuritis, which is kind of pain in one or both eyes, but then again, it gets better. They may have that muscle weakness, and oftentimes it'll start maybe on one side of the body. They may have progressive numbness, but again, it gets better. The symptom that I've heard overwhelms them the most is fatigue. Dysmetria is that inability to direct movement. Paresthesia is the numbness. Maybe they feel like they have pins and needles in their skin. Hyperalgesia is they could have a reduction in sensitivity to painful stimuli. Ataxia is impaired coordination. Depression, altered sexual function. Dysarthria is slurred speech. Dysphagia is where they have the inability to swallow or difficulty swallowing. Diplopia, double vision. Nystagmus is that involuntary eye movement. Scotomas is the change in peripheral vision. So there are a lot of things that we see with MS. And we may not see all of these things happen at one time. It's a process. They may have that slurred speech and then they get better. They may, maybe have times of difficulty swallowing and then it gets better. Again, when they are exacerbating those symptoms is when that damage is occurring. So we want to prevent these things from happening. They may have a flaccid bowel or bladder. They may have constipation, depending on how sedentary they become. So again, we need to think of interventions that we can help these patients. Things that we can do for their bladder, retraining their bladder. How do we retrain a bladder, or how do we try to? Put them on a schedule. Yeah, taking them to the bathroom, still letting them drink their fluids. We don't want to restrict people's fluids for this. We still want them to maintain that fluid intake, but then we're having them do a schedule, maybe every 30 minutes, every 45 minutes. But we're just retraining that bladder. Things for constipation. I mean, obviously, again, we're not restricting fluids. Exercising, getting up, and we'll talk about exercising here in a second. With these patients, things that can exacerbate these symptoms could be an infection, so if they get sick. Very warm climates. So we probably would not see these patients going to Bora Bora or Mexico, laying out in the sun because the heat can actually exacerbate this. If they like to run marathons, we probably would tell them not to because anything that increases their internal temperature. There's a sign that we may see with this that the physicians may do right as soon as they see a patient, and it's not one, we can see this even with meningitis, but it's called Larameets. Larameets sign. A physician may do this right off the bat when they think it could be MS, and the reason why is because what they have the patient do is flex the neck, and if they feel a kind of like electrical shock down their spine, that's a positive sign. But again, it's not a diagnostic for MS because they can just maybe see, okay, something, it could be MS. Diagnostic testing, again, there isn't a really great specific procedure with a lot of these. MRIs, again, can see those MS lesions if it's been going on for a long time for these patients.
Is Larameet something that you see or something that they tell you?
That they tell you. And then CSF, increase in protein, we may see due to the myelin, the breakdown of myelin. Drug therapy. The only thing I really want you guys to get out of these medications, because even some of these patients are on different antibiotics because if they think or assume, you never should assume, but if they possibly assume that it could be an infection, they may start them on antivirals, they may start them on antibiotics. Again, this is all being tested. What they do know is these medications can work. So what these medications are, most of them, are things that can cause suppression of our immune system. They may even cause our immune system to work better, but most of the time it's to cause our immune system to be suppressed. So the first medications, the interferons, these medications may have flu-like symptoms. These patients may be put in the hospital due to the flu-like symptoms. They may have suicidal thoughts. What are things that we do if we have patients on some of these medications that cause a suppression in the immune system? Avoid large crowds. I think I've heard that. Suboxone can cause anxiety. Tremors, difficulty breathing, natalizumab medication. What is it?
That's an easy for you.
Yeah. Can cause progressive. So these are the big ones to know. And due to if you are educating a patient on taking these medications, because they really need to let us know about these symptoms. Can cause leukoencephalopathy. is an infection of your brain. Again, difficulty swallowing. Motrin. These patients are at risk for leukemia. There's a cancer treatment. Can cause cardiotoxicity. Pneumonia. Take with food. It can help with facial flushing. You have corticosteroids. Which causes what? The same steroids we always take. What can it do to us?
Sugar levels.
Yeah. So a big thing is monitoring their glucose. So with all of these, the big ones, especially this one, you want to remember. I mean, if NCLEX is going to test you on important medications of any treatment, it's going to be things that can kill you. This can kill you. The Novitrone obviously can cause leukemia, so that's important to remember about some cancer treatments. But it can, I mean, even though it's a cancer treatment, it can also cause certain types of cancer. So avoiding, if I was going to test you on these things, you want to know that if it's messing with your immune system, then you need to be cautious with your immunity. So would you go out to a big party without a mask on or protective measures? No. So those are things that you would want to kind of talk and discuss that with your patient. Add-on medications we may see for these patients would be things like Ditropan. Ditropan helps with incontinence, urinary incontinence. Baclofen. What's baclofen? Muscle spasms. So that's why we see medications like that would be an add-on. Again, for the symptoms that we see.
What was the urinary?
Ditropan. So even though you're not going to be the one prescribing these kind of medications, if somebody's they're like, oh my gosh, this is really aggravating. I'm constantly leaking out of my bladder. It's really upsetting me. It's embarrassing. I like I have to wear diapers. There's something that you can do about it. You can recommend that to the physician and say, hey, why don't we try our one Ditropan? Yes, Ditropan has anticholinergic effects because it dries them out, but they can still kind of feel like they're living, a normal life, and they don't have to feel so embarrassed. I'll give y'all a break in a second. Non-pharmacologic therapy, so PTOT. We may need speech therapy depending on, how worse they get or how bad they get. But again, these patients can live a normal life. If we can keep the exacerbations at bay, they can live a normal life. They may have to walk with a walker, things like that. My husband, the place he grew up on the church, his preacher's wife was on, she was in a trial for this. And they were doing all kinds of antibiotic treatments, antiviral treatments, just trying to figure out what would help her. But I mean, she's walked with a walker 10 years ago, and she's still the same. So I think that's pretty good. They're keeping it where they should. Suitable home environment. So again, throw rugs, small animals, electrical cords. That's always a big one. If they have to have electrical cords running in the middle of their floor, what can we do? Tape them down. Complementary therapies. I've heard a lot of these patients will go maybe with those needles. What's the needles called? Yes, acupuncture. They say that really helps. Massages, yoga. Now again, are we going to tell these patients to run them off? Please don't do that. Frequent rest periods. for these patients. Anything to keep their body temperature normal, not, we want to refrain from elevating their temperature. We want to plan their activities. We don't want to say, let's go walk around Disney World and go do everything in a day. Light stretching can help with their muscle spasms. I always recommended my patients to do like maybe water aerobics because that keeps them cool, but it's also helpful for their muscles. We want them to remain free of infection because again that can cause exacerbations. You may even be able to send them somewhere to a gym or somewhere that maybe you can do an exercise program with them. And we'll stop here. Y'all take a break, breather.